Well, welcome everybody. I know it's early for some people and late for others, but thank you so much for joining. So I'm Pat Price. I'm co-founder of the GCR, and today's session, as you know, is going over this phase 3 of our essentials document. So just a few housekeeping questions. Please use the chat box to introduce yourself. It'd be great if we had your name and where you were from so other people can share. Also, if you want to ask any questions in the chat box, they'll bring them to the attention of the panelists during the round table. And then we wanted to go over what our plan was for today. So we've brought together, as you know, this wonderful group of panelists, WHO, Cancer City Challenge, experts from cancer plans and lower middle income countries. And I know Mary Gaspadarovich kindly moderated our phase 1 webinar, which is a huge success. We've had a lot of people join us since then. And she and others on the call today will be supporting the completion of this essential standards resource. So our aim, obviously, is to get a document that we can have and as essentials that can be used for radiotherapy within national cancer plans. And how we did this in our phase 2 is we broke it down to the key components that we would develop, and with our expert panelists from all around the world and also bringing industry into the table, we formed working groups full of fantastic volunteers who've been really working hard over the summer, contributing to the key components that we've identified during that phase. And now over today and our next webinar on the 24th, we propose to go through those working parties and hearing from the group leads and hearing about what progress they've made. And this is an opportunity now for everybody to contribute. We'll ask some questions, and really the leads want to have feedback. Are they going in the right direction? If we missed anything, and then we can move forward to trying to put all this together. We're preparing a soft launch for a big and in-person and virtual event at London Global Cancer Week in November the 14th. You've probably seen the registration is available on the GCR website. And then after that, we're hoping to really finalise it with multiple inputs and getting this published into next year. So again, if we'll lead off in 3 areas today, with Hanna talking about the data and monitoring, Sarah talking about advocacy, and then Ajay Aggarwal is joining us after half time to talk about AI into cancer plans. So I thought if we went through all 3 sections, and we can ask questions, brief questions at the end of each session, and then some more at the end. But please, you do use the chat box because we can get in touch with each other that way and those sorts of things. Okay. So shall we start then? Tim, do you want to kick us off then with your fantastic data and monitoring work you've been doing?
Excellent. Thanks, Pat. So I'm very excited to share the initial recommendations of our data and monitoring essentials work group, which will feed into the Essentials for Radiation Oncology and Cancer Controls Plan project. These are the working group members, excuse me, and really excited to have this experienced and internationally renowned group of individuals. We had a lot of excellent interactions, and a lot of feedback has come in as we worked on this over the summer. Next slide. So why do we need data for radiation oncology? I don't think I need to convince anyone of the importance of health data, but why are there essential data elements? This exists because we need to have access, quality, and value at the highest possible level for the national radiotherapy programs around the world. Access could improve the length of life or quality of life of many with cancer at the national and international level, because, as you know, 40 to 60% of individuals diagnosed with cancer will have an evidence-based indication for radiation, and many of these are irreplaceable by other techniques. And achieving these benefits, as we saw in the Lancet Radiation Commission, could have important net economic benefits. Next slide. So examples of essential data use for access There are key elements of the data that are crucial for planning human capacity and capital investment. For example, for capital investment, we need data and country level and regional level information on supply targets, demand, machine throughput, and machine and staff numbers to volume forecast. For quality, there are many dimensions of quality, but for example, we need essential data for monitoring the daily operations of the cancer program and the radiation program, for monitoring of safety and waiting times. For value, we want to avoid waste. So for example, we want to be sure that everyone who has evidence-based indications supporting hypofractionation will get a shorter radiation treatment where it is appropriate to maximize the use of resources. Next slide. So there are many classes of information that are important to run a radiotherapy program. I'm going to focus on patient-level routinely collected data because of its importance for monitoring at a higher level, but all of these are extremely important, and I'm sure we could have long talks on each of these elements of the data. Next slide. So I'm going to provide top 10 lists of principles that are important to consider when developing a data platform for a radiotherapy program, focusing on routinely collected data. Next slide. So number one, we recommend a resource stratified approach to population coverage. So for example, in a low-income country, you could focus on high quality institutional registry data plus regional surveys to fill out the information that's needed to run the program. And that goes all the way up to what we call the optimal level, where there are streams of data that in many high-income countries we don't yet have. For example, an RT DICOM data central repository. Next slide. So number two, it's important to maintain a unique identifier across all health administrative data sets, and this allows you to maximize the use of all of these very important data sets. For example, it's important to have a linkage between the cancer registry and radiation records both ways. So this can be important for the registry to identify people diagnosed and treated with cancer, and also for having a denominator in order to define actual radiation utilization in a country or region. Next slide. And it's important to integrate the radiation data with the rest of the cancer system data. And that can't be overstated. This is a whole system we're talking about developing essential data for. So really, we need to develop that whole data system as a package. Next slide. And we recommend using an international data standard. And this is important for interoperability of the data, both between institutions and regions, but also between countries. And one data standard that has really received a lot of collaboration from multiple stakeholders, including ASTRO, ESTRO, CARO, AAPM, and others, many others, is the HL7 FHIR Codex Radiation Therapy Data Standard, or FHIR. This is an important standard to think about, and it may be the one that is considered for an international standard. Having an international standard and allowing us to have interoperable data is important for things like benchmarking, measuring, and comparing quality indicators, both at the national level and internationally. And I'm sure we'll hear more about this when we talk about quality. Number 5, it's important to, of course, consider principles of privacy, confidentiality, and ethics. And this requires a plan and clear policies and statements. It's also important to obtain upfront patient consent for data sharing and access, which is important if you run into emergencies or natural disasters, such as what happened in the Ukraine, where you may need to treat cancer patients in other regions and thus have connections and interoperability of the data. In terms of ethics, principles of fairness, ethical use, equitable use, and consideration of potential for bias in artificial intelligence algorithms or other approaches are important when using and developing the data platform. Next slide. It's important to have longitudinal funding for information technology and analytics capacity. You don't just want to have a beautiful platform when you start on day one. You want to maintain it, expand it, and use it to its full potential for as long as your radiation therapy program exists. Next slide. And you want to have continuous data collection, and that just goes with the previous principle on number 6. Next slide. This interoperable data, as I was talking about a little bit before, is important for peer-to-peer international comparisons and benchmarking. And it also highlights the need to have widely accepted quality indicators that are important for the radiation program and also are agreed upon across multiple stakeholders. Next slide. And we need to harness automation. And this is an area where further evaluation is needed for the various possible applications of artificial intelligence. But I think it's just a matter of time before we see even more applications of artificial intelligence. And certainly we want that to be as evidence-based as possible. And this could be use of AI in clinical decision support, for aiding in decisions for resource allocation and maintaining safety of the radiation program, among many other possible applications within cancer control. Next slide. And finally, we want to ensure patient access to the data. You should consider a mechanism for patients and their families or caregivers to access and control their own data for many reasons. Next slide. So what data should we actually collect? When we were talking as a working group, we divided the elements of possible data into essential data, expanded, and optimal. And you could call this priority 1, 2, 3, as the O3 group has done with their recommendations. But here we call this the essential data elements. And first, as we've talked a little bit before, having a unique identifier across all the administrative databases is part of essential data. Also, we'd recommend the importance of collecting data on all patients, not just those receiving radiation, and that relates to having some form of cancer registry in place that this data flows into. In terms of patient data, we recommend the importance of patient date of birth, sex at birth, vital status, and performance status. These are important elements in order to understand equity at a high level and patient characteristics for adjustment, among other things. Disease data, this is the list. We recommend collecting the date of cancer diagnosis, the body site and pathologic type of cancer, otherwise referred to as the topography and morphology, and also stage. And within stage, as you know, there are various staging systems. The UICC and World Health Organization have an essential TNM staging system, and we talked a bit about that as a potential essential form of staging, but this is one that could be discussed further when rounding it out. Next slide. And finally, treatment data. And I'll just say that when we were putting this list together, we thought about the importance of these variables for ensuring optimal access, quality, and value of the radiation program in the cancer system, and also the feasibility of data collection. And many of these items are automatically collected as part of a radiation information system. And so some of these, for example, you won't see in priority 1 of O3, but we felt that these were important, and we can have further discussions about this. So this includes the treating cancer center ID, because you want to identify regional variation, and so you need to know where the patient is treated. A radiotherapy episode identifier number of fractions, dose delivered, the body site treated, including laterality, treatment date and time, intent, and also modality. And this allows some tracking of the types of treatments that are happening, including use or non-use of hypofractionation in order for quality improvement and monitoring. Next slide. And this is just a summary of what these essential data elements could do in part. So they could be used for measuring radiation utilization, for human resource and capital planning, measurement of quality, such as waiting times, particularly the interval between diagnosis to treatment, effectiveness, measuring various cancer outcomes by stage and treatment protocol, particularly survival. And measuring value. For example, these data could be used to feed into model-based economic evaluations and monitoring of use of RT technologies and hypofractionation. So I'll stop there and look forward to your thoughts on these draft recommendations, and also in terms of our future work. Once we've received more feedback, we can think about developing further recommendations on implementation. Thanks.
Tim, absolutely great. Thank you so much. Mary, a question.
So Tim, this is excellent, as expected, obviously. I have a strong plea to not use resource stratified language, but maybe data maturation level. Just like, you know, when people try to get digital, there are levels of sophistication that people go through. Because once you put resource stratified, people say, oh, we don't have resources, and it's a great excuse not to collect data. And as you know, the data exists, it's a matter of capturing it, right? And you could say, instead of sort of, you know, low-income country, middle-income country, you say the essential data level 1, then level 2, level 3, and different institutions, different countries can have different levels. Even, as you know, in Canada, different provinces and different institutions have different amounts of data, right? And that sort of creates maybe a little bit of motivation. Oh, you know, this institution has more data than I do. So that's just one comment.
Thank you. Yeah, that's a brilliant comment, and yeah, we can definitely do that.
Yeah, Mary, great, because I think that's come in from another few people as well. What is the essentials of different places that would do it? We've got a comment in the chat from John Ryland from Australia asking about whether we should go as far as collecting IGRT protocols and imaging data, or is this going too far? What do you think, Tim?
Yeah, it's I think a lot of it I think does boil down to how easily this data is collected and the resources required to harness it to guide the cancer program. So I think it could fit somewhere in there. Maybe not as level 1, but maybe one of the higher levels. I think thinking of
Level 15.
Level we're still getting there in Ontario, you know, in developing a DICOM RT database for the province. So we all have room for improvement.
Yeah, no, great. Amanda, you had a question.
Hi, so Amanda Casey, just chiming in about the O3 efforts under APM. So, I mean, Tim, your work is coming right as the publication came out for the international standards, and they set their level of priority. So, not saying that yours is necessarily wrong, though, because that group was just giving, I would say, expert consensus of what they thought was feasible or critical. So the one thing I'd like to say is, if you have such a well-organized group doing this effort, I really think we should give a mechanism for you to be able to feed back to that AAPM O3 group that's looking for community feedback on this. Because in fact, you know, they may change over time what they're recommending for implementation, prioritization based on your work and what's feasible in centers with different resources.
Thanks, Amanda. Yeah, I think that would be brilliant and really strengthen what O3 is doing. It would be, there's no point reinventing the wheel. I was really interested at how close a lot of our levels are mapped onto what O3 is doing anyway, even when we hadn't looked at it before we had our meeting. I think the one thing, as I was pointing out, was just some of the elements of the radiotherapy data was more a level 3 third priority thing in O3, and definitely, I mean, this is open for discussion.
I also think that it's important to keep in mind the purpose. I mean, Pat put forward clearly the purpose. The purpose is to make sure that the planning and evaluation of the plans is feasible. And I think when we talk about data, everybody wants to more. It's important to make sure that we understand the purpose and then we use the data for that purpose. That doesn't just sit there, right?
Good point. And I liked, Tim, your slide about the outcome and what these areas are going to be useful, because really having sort of key outcomes is really crucial. And I must say, having trying to be making the case now in the UK, it's amazing how important data is, because if you can provide that evidence base, and also I'm very proud of the international work in radiotherapy. You can say, look, we're really good at this and we've really thought it through. And it's a huge strength. And I think we've got a lot over other people. So that's great. Well, look, we'll leave that one there because we must press on with advocacy, but please add some more things in the chat, things if you'd like to do that, and or write in. And I know, Tim, you're going to complete and carry on with this work. Okay, so thank you, brilliant. So Sarah Quinlan now has been looking after the advocacy group, and you're going to share with us how you're getting on there. Thank you.
Yes, thank you, Pat. Hello, everybody. So yes, my name is Sarah Quinlan, and I am the director of Radiotherapy UK. And our group was tasked with collaborating to develop what role advocacy plays in ensuring that radiotherapy is a key part of a cancer plan, and to think about what is needed for successful advocacy. So, I mean, everyone here, we're all in the radiotherapy community. We all know and understand the importance of radiotherapy and the difference that it can make for cancer patients. But what we really need to do is to be able to take that information and convince other people of it too. And it just, I can run through kind of our, what we think that looks like with cancer plans, but just first of all, say a huge thank you to the working group members who collaborated with me on this. You can see them on the screen there, and for their enthusiasm and for their time in pulling this together and their insight and expertise. This is a working document, so we're very much open to feedback and further comments, but I'll just take you through some of the things that we think were really important. So the three areas we're looking at was the essentials, a checklist, and then implementation. So first of all, the most important thing about advocacy is understanding what the issue is that you're advocating about. Every country has a different set of circumstances, and we'll be working with different types of governments, systems, with different funding infrastructures, and the countries are also delivering radiotherapy to variable degrees. There's a lot happening within what we're trying to achieve within this document, but we've thought we would be helpful to kind of put down like some of the examples of what issues are. So it could be wider issues like developing overall access to radiotherapy, specific changes needed within workforce, within technology implementation, within planning, and also this overarching piece about the increased incidence of cancer that's coming. You know, we all know that more people are getting cancer. What is going to happen? What are the future plans being put in place? And what's really important about when you advocate is that you're not only putting forward the problem, but you're actually putting forward a solution as well. So we need to be thinking about, well, how can this be resolved? Is it a policy change? Is it that there is additional funding needed? Is it something that can change in processes? Is it workforce planning? Within the group, there's a lot of discussion about the need for focusing on recruitment and retention of the workforce and how we promote radiotherapy, and the need for you to audit, manage, and plan. And a lot of the data information that Tim was talking about filters in there as well. And again, the solution can be any number of these things, but we really need to be very clear about how you see the solution and what that looks like. So moving on, we were looking at the importance of identifying your audience. And in this point, it's the people who make the call, who have their hands on the purse strings, who make the decisions about radiotherapy. So whether that is your health system that you're operating within, whether it's the relevant government departments, whether it's federal or regional. It will, again, be different for every country, but it's really important to know who is the person who actually makes the decision about what changes for the issue that you would like to see resolved. Understand your environment that you're operating in. So there will be the policy, there will be the health structures, which probably people will be familiar with within the radiotherapy community. But it's also thinking about, well, what's happening in other countries? What data is being collected? What could we collect? And what's available that you can then maybe do a bit of analysis on yourself. At Radiotherapy UK, we would sometimes be looking at the international research and reports and then pull it together into something that we can use as a briefing. So we're doing our own analysis of different data that's available to us. And again, thinking about what are the barriers. Istro here, we're doing some fantastic work around this. What's the need for radiotherapy? What's the status of radiotherapy within Europe? And looking at economic evaluation models. That sort of work is incredibly invaluable to support the environment that you're operating within. So moving on to your stakeholders. So stakeholders, there's probably a few different levels within stakeholders as we talked about it. There's the stakeholders who will be impacted on now. So we have patients, and in the future, with your patients, you have your workforce. And then you also have the platforms of stakeholders who will help you spread your message. So again, looking at media, the press, who can help promote and highlight the work that you're doing, the need and the solutions that you are putting forward. And also then we're thinking about, well, who can influence? So these maybe aren't the decision makers, but you're thinking about the people around the decision makers. Who are they listening to? Do they listen to health bodies? Is it the professional bodies? Is it the industry as well? So it's really, really important to do a very good stakeholder analysis of who influences the decision makers, and actually who's impacted too. And working in collaboration with your stakeholders will provide a much more powerful statement and also help you understand the issues so much clearer. The next step would be then your project plan. So again, this is what do you need to deliver? This is almost a nuts and bolts and is crucial for anything to succeed. So we talked about looking at your strengths, your weaknesses, your opportunities, and your threats, and consider resources. We're a charity, and resources are, always a question for us as well, because most charities, NGOs, patient organizations struggle for funding, especially in the current climate. So you've got to think, how do we actually work with other people, other stakeholders to maybe combine our resources and create a campaign. And then think about what it looks like. What's your timelines within this? And what are the actions? Is it a big national campaign, or is it a smaller targeted with just the people that you think can make the change? And within key messages then, communicating. So there is the starting point of what is radiotherapy, which within our working group we discovered is not an easy question. And there are many different answers to that. So it's also about thinking about, well, how do we create information that is really simple, really easy for people to access? And because we're not talking to people in the radiotherapy community when we advocate, we're talking to people outside of the radiotherapy community. So we have to think about how we translate all the information and the expertise and the knowledge into something that's quite simple and easy to understand. And make it really interesting. It is fascinating. I mean, I'm learning as I continue along within my role, and I'm totally fascinated by the work that's undertaken in radiotherapy. And it's also really important that it's fact-based. Your key messages need to be grounded in fact and evidence. But what I would say about that is that I know that data is king or queen. However, what is compelling is people. People are who help you get your message across. And in that instance, it's really, really important to have very good case studies. And it doesn't always have to be patients. It can be workforce. It can be, people around this table, people explaining what it is they do as a person, rather than maybe the end piece of their work. That's really, really important. and show the impact. You know, if we can do this, then this is how many patients will be treated. If we can do this, this is how much quicker our capacity will be. Give people the solutions in a picture so that they can see where you want to get to. That's a really key part of messaging. And there's lots of tools out there already. So it's about looking at what's around you. There's really good existing advocacy tools. GCR have done a lot of work in this, as have Estro. So in terms of the key messages, there's a piece of work to do here in communicating what you all do and making it incredibly compelling. So we have created a checklist, which I'll just pull out one or two things because some of them are replicated in the above. But I think one of the two or three things I would pull out would be look at best practice internationally. Again, that's or look at can be best practice for what's happening in the countries close to you. To have that comparative is very strong. It doesn't always have to be, well, this country is delivering optimum, and that's going to be very, very difficult for us to get to. It can be a country with similar resources is doing this for their cancer patients, is doing this within radiotherapy, and that can be stronger. Explore champions. Try and find the people, whether it's cancer patients or people within your community who can influence outside of the health world. You know, that's really important. You really need to lift this potentially out of radiotherapy and into wider health issues and into the wider public conscience as well. That's a big step, is whenever you can start gaining recognition outside of the health world. And building connections. I mean, I suppose I take every opportunity you can to meet whoever you can, because these sorts of connections, whether they are with local politicians or they're with professional bodies or they're with other patient organizations, they're really, really important to help you meet your goals. And within the implementation, it is very dependent on what resources you have, but it's always really important to be transparent and accountable about where the money is coming in from and where it is going to, especially within advocacy work. So do consider where you can get your finances from. There's grants and trusts out there. You could work with the industry, partnerships and corporate. How are you going to deliver this? Is it going to be something that's done in-house or with a company or through networks? Really importantly, if we're working with patients, is by patient confidentiality and data protection, and also making sure that the patient is very much a part of any case studies or anything ongoing and are aware whenever it will be used and in what capacity. What I would say is that milestones are important, but advocacy is very hard to evaluate. You know, we are working in an environment where you're responding, and you're also working in an environment where you don't have control over what governments decide is their priority. You can get in there and advocate for it, but government's priorities can change and shift regularly. So you need to be realistic within that. Top tips. These are things that we thought whenever we came together as a group, we thought these are the sorts of things that we, in our experience and our insight would come through, is very much remain politically neutral. You know, the issue is not that we can talk to different governments and we can encourage them to do things, but whenever you're advocating, it needs to be that you work with all political parties or any MP or parliamentarian who shares your vision. Be prepared to take all opportunities. As I said, you know, things arise, and advocacy doesn't start one place and start in A and end in B. It'll visit C, D, Z, P along the way, and then you might get to B. And be agile. One of the things we talked about was trying to prepare materials in advance so that when an opportunity arises, you have everything that you can give over at the time. So again, reports, analysis, case studies, you're not looking for them when you need them. You have them ready to go. And be ambitious. That's what I always think. You have to, in some instances, ask for the optimum to get 2/3. But if you ask for 2/3, you'll get 1/3. So you've got to be ambitious in your ask. And own the campaign. I mean, you want to be the trusted expert in this area. And be that expert. Take it on board and think, yes, you know, I know this and I can communicate this very well. So we just thought then about other things we'd love to do off the back of our conversations, where like the creation of generic slides, where people can put in information about their different countries, and also just really creating an environment where it's easy for people to advocate, that there's tools out there. I know GCR have created a really good advocacy toolkit, and maybe the next step on for that is some really slides that can just be lifted, or resources that other organizations, advocacy groups could take forward.
Great.
And there's some links there too.
Great. Fantastic, Sarah. Look, that was really comprehensive. I don't want to take questions just yet. If we could leave those to the end, because I know Ajay's just come on and he's got to get back to some patients in clinic. So if we can just switch now to Ajay's talk. And welcome, Ajay, and thank you for making the time. I know you're in the middle of clinic, but you're going to tell us all about AI and cancer plan, and then we can take some questions, and then Sarah, get back to you about the advocacy questions at the end, if that's okay. Thank you. So Ajay, fire away, and thank you for rushing in and out.
No problem. No, thanks, Pat. It was best laid plans. Told everyone 2 weeks ago that I need to leave early, but lo and behold, there are 4 patients waiting. But anyway, we'll be fine. So anyway, thank you very much for the invitation. And I've had the pleasure of meeting many of you online. So hello again, and look forward to meeting many of the others who are online as well. So the actual presentation scope was around AI and cancer plans. So what I intend to do is just to give a bit of a scope around AI full stop per se, some of the opportunities and challenges, and then talk a bit more about a trial that I'm currently leading looking at AI in radiotherapy specifically. So there are 2 halves essentially, and more of a broad overview. So I know there's much more detail one can give, but I just wanted to give people a flavor of what's going on. So I'm going to start off with a slide which obviously many people have seen, which is that we have an access issue in terms of radiotherapy. And that's one of the reasons why we're here now. This work is relatively dated to some degree, but I think the figures are still particularly stark, which is approximately 10% of patients from the lower income countries, particularly sub-Saharan Africa, have access to radiotherapy who need it. And that goes to about 40% in middle income countries. And I think from a middle income perspective, one of the things is actually have the sort of dual thing of the increasing burden of disease, the increasing volume, and a need to actually rapidly escalate the number of services offered to meet that demand. So then one of the questions when you reflect, and many people have been on the global task force who are on here today, I think Mary's here, and one of the pressure points clearly with boosting access is on the one hand there's equipment, but on the other hand, I think one of the critical factors is expertise, and the fact that actually radiotherapy is a broad church and who you need to deliver excellence. So that's medical physicists, treatment radiographers, radiation oncologists. And I think the estimates that were given are probably relatively conservative for what's required by 2035 globally. There's nearly sort of 150 to 200,000 new staff to actually deliver demand expected at that time. Now, we have to be frank, as much as one can improve training, and there are lots of amazing initiatives that many in the group are involved with, we're simply not going to meet that. So we can have all the equipment in the world, we can have great hospitals, we can have all those different elements, but we're not able to have the staff to actually manage the components of the pathway, then we're really going to struggle. And so I think a lot of work and innovation in that space is particularly looking in that area. So I think one of the things around innovation is what's led by the market and what's going to meet public health goals. And the WHO had a lot of foresight in this regard in terms of meeting universal health coverage to give affordable and equitable care, to see that actually in terms of innovation, there are a number of public health goals that it could meet. So one aspect is unsolved medical needs. Another factor is how to use all the plethora of information we have from the electronic health records to start to be able to develop new information about prognostication, how we manage patients, and to start to improve outcomes. And I think here in particular, digital innovation has the opportunity, as many of us know, for managing one of these acute crises that we were talking about, which is personnel. But in terms of personnel, particular tasks that personnel are doing or needed that can actually be automated, or elements that can reduce the need or friction in the system when it comes to referral pathways. And I think there's a really good example. I don't know if people have heard of Peak Vision, which is essentially a phone app where people in the communities, and this was first trialed in rural Kenya, where they take pictures of do eyesight tests and can take pictures of the patient's eyes, which is then beamed up to central hospital in one of the major cities, and they can then pass through to see who needs referral. And it's made a huge difference. So these are things where it can really have impact and be able to deliver excellence or competent care at speed. But one of the things that I've mentioned here in the yellow is that digital technologies have huge potential, but it's absolutely imperative that they're clinically robust, i.e., are they going to do what they say on the tin, and also affordable. And that needs evaluation. And so I got one of my clinical fellows who was interested in artificial intelligence to do a search of all the studies looking at AI with a particular focus in cancer and in the post-diagnosis phase. Poor thing looked through 12,500 studies, but in the post-diagnosis phase, only found 15 studies that were doing a prospective evaluation of AI. And they were things looking at prognostication, some in radiotherapy, many different elements. So it was a complete broad church of things. Worrying factors were they were small scale, often single center studies, and in high income settings. So there was nothing from the low and middle income country setting. The reason why that's important, because I've done a lot of development work for AI, is that actually a lot of the studies that exist outside of these 15 is that, we've got data from this hospital or this group of hospitals. We've developed our algorithms and now we've tested it in the 10% of cases that we didn't use to train the cases. Now that's different. What they haven't done is taken those algorithms and see, well, let's try and test it in diverse populations with different stages of disease, different systems of electronic infrastructure to see, does it do what it says on the tin? Is it going to save time? Is it going to save cost? These are the critical questions that we want for global implementation of things that work. The other factor, and this is a caution, is something that William Baumil came up with. I think it was in the 70s or 80s, actually. And he was talking about digital healthcare and about productivity. And one of the things is about digitalization or technology is that in many, many industries, car industry being a particular one, technology, when it's integrated, has increased productivity. But it's extremely hard to increase productivity in healthcare from technology, partly because you can't substitute humans to perform surgery, biopsies, to look at imaging, to take a history. So all those different elements. So you often have limited gains from technology. The other factor, though, where technology does work, often means that actually you're finding more people who need the treatment in the first place. So you then end up needing more doctors, so that increases the cost. And the third thing is, well, actually, as it gets more specialized, you need more experience. More experience is more costly. So we have to be careful with saying that technology is going to save us cost in the long run. And that's why it's important, in general, technology increases the cost of the health service, but we want to deliver care that improves outcomes, allows people to live longer and better, and adds to the sustainability of our service. So that's just a sort of general caution when we're talking about AI and cancer plans, and what are the things that we should be looking for when we say, yes, we need this, we need to integrate it, and it needs to be done at speed because it will make a big difference to access challenges or quality challenges. So in terms of radiotherapy, which is why we're here, there's been some work, and I think many of you would be aware of Lawrence Court's work at the MD Anderson for the radiotherapy planning assistant. And this was work that commenced in 2016, which was looking to be able to create AI algorithms that could, on the basis of a CT planning scan, both contour and plan in one sitting. Now, the development phase was done with partners in Sub-Saharan Africa, particularly South Africa, Southeast Asia. And over the course of the last few years, they've been able to develop these tools, which they've retrospectively validated for head and neck cancer, cervical cancer, moving towards prostate cancer. And I think one of the unique things was, it's available by an online portal. Second of all, it was tested and developed in the low and middle income setting. Third of all, it does both the contouring and planning together. So those were three factors, and they've now got FDA approval for this. And one of the key advantages or thoughts are that this could potentially shave off, particularly for medical physicists involved in planning, which is particularly in terms of the distribution of the work in the low and middle income country settings, predominantly done by medical physicists rather than dosimetrists, but also the contouring of organs at risk and lymph node volumes could save a huge amount of time. And so they've published papers over the years showing around the clinical acceptability, and some work around time savings. But the way, when I originally approached Lawrence Court, who've been working with for a number of years, was actually, how are we going to actually integrate this? How are we going to show that this is both affordable and robust in terms of having prime time implementation? And so this spawned the idea of archery, which has started about 3-4 years ago in terms of the idea. And then, as with all these things, it takes a bit of time to get funding for it. But I'm pleased to say we're a year into the study, and the archery study was designed to be a prospective evaluation of the radiotherapy planning assistant, so automating contouring and planning in 3 tumor types: cervical cancer, head and neck cancer, and prostate cancer. It's a global collaborative. So in terms of the recruiting sites, so 2 in South Africa, Stellenbosch and University of Cape Town, 2 in India, Tata Memorial in Kolkata and Tata Memorial in Mumbai, University of Malaysia and King Hussein Cancer Center in Jordan. Also, because of the multidisciplinary nature of it, quality assurance. So we've got Peter Hoskin and Liz Miles's team from the UK involved in that. Costing analysis that's going to be done by Yolanda Liebens, for those who know her, is the sort of international expert at that. And then we have the technology, which has been developed by the MD Anderson. So this was as much about a collaborative of bringing different groups together to deliver an international study. And the actual study is situated in the MRC Clinical Trials Unit, again, because they have expertise in running global cancer trials in the sort of low and middle income country setting, which needs its own degree of expertise. So just taking you through that, they have a portal which allows contouring and planning. So what we wanted to do in terms of the study design is just very a basic schematic, and offline I'm very happy to discuss this, and our protocol paper should be out in the next 3-4 weeks. But we know in a standard pathway, the CT scans taken. So people eligible for this is anyone who's going to be having radical treatment for head and neck cancer, cervical cancer, or prostate cancer. So these are patients who've already consented to receive radiotherapy with curative intent. CT scan is done, the GTV is contoured, and then the nodes and the organs at risk, and then they go planning, and the patient gets treated. So that pathway is going to be timed. But after the GTV has been contoured, it's then going to be uploaded to the radiotherapy planning assistant. And that will contour the nodes, elected lymph node fields, and also the organs at risk. It will also do the automated planning. That pathway will be timed, and the plans produced by that is what is going to be evaluated. So we're going to evaluate the actual AI-produced contours and plans. The patient's pathway will continue as standard. Our primary outcome measure is overall treatment plan acceptability. So we want to see whether the contouring and planning meets the gold standard for evaluation, not whether it's better than the manual plans currently done, but whether this would be acceptable in any region, hospital, country in the world, according to guidelines around contouring and planning. We aim to recruit 990 patients, so it's powered with a 95% plan acceptability. So we've got quite a high bar that we would say that 95% of contours and plans together as a composite would be acceptable. And that means we need to recruit 330 patients per tumor type. And sample size will allow us to rule out an acceptability rate less than 90%. We've talked about the sites and the countries, but another major component, because this is about implementation in diverse regions with different types of tumors, the size of the tumors, etc., is actually the time and resource saving. Again, that's very specific because everyone's skill mix is different, the efficiencies in every hospital is different, and also the IT and processes. You don't really know the time and cost saving unless you do it properly. And so we're going to time the manual and automated approaches. And one of the things that we do is also try and put this into the time-driven activity-based costing model, which was developed by Yolanda. So what that does is it takes a baseline. So for every procedure that's done in the hospital, for every tumor type, it looks at the contouring, the plant production, the QA check. So everything is given a time. And so what happens is once you've derived a cost for that, and knowing the overheads, you then substitute the timing elements within that pathway for the automation to see, well, actually, what is the cost saving from that? And you can therefore also look at a budget impact analysis. The other factor is that each hospital will, once it's run the time-driven activity-based costing model, will be able to use that to work out reimbursement tariffs, any other innovation that comes in, to see whether they actually want to change anything themselves going forward. So that will also be a resource that they can use going forward. In terms of where we're at the moment, so as you can imagine, people talk about we need to do these global radiotherapy trials or these studies, but they're very startlingly few because it's hard. It's hard to get funding. It's hard to bring people with the right expertise. It's hard to find the right infrastructure in terms of research to be able to deliver it. With the protocols in place, the ethics are in place, the contracts in place. And so we're aiming to start recruitment in the next 4 to 6 weeks, I'm pleased to say, which is fantastic. And so it will run for a couple of years in terms of recruitment. I think in terms of its proposed impact, well, it's the first sort of global radiotherapy study of its type in AI, looking to support implementation in different health systems. So the affordability and the robustness that we're looking at. If it does meet its endpoints, the AI software will be made not-for-profit as a web-based service for public sector hospitals in resource-constrained settings. It's also adaptable. So we've designed it as a multi-arm study. So originally the funding from the NIH was for cervical cancer and head and neck cancer, but we were also then able to add in the prostate cancer arm following funding from the Rising Tide Foundation. And so as the technology develops for contouring and planning, we could add in other arms or equally new sites potentially. But I think at the present time, it will be at these sites. And the aim is to try and overcome lack of workforce to expand services at scale. And we look forward to reporting back. Happy to take any questions, and particularly like to thank our funders, because actually there was no funding for this within the UK, or there was a dead end as such. So the USNCI for its vision, and the Rising Tide Foundation, and all my collaborators who are brilliant to work with. So thanks very much.
Oh, Ajay, absolutely fantastic. I hope we're all blown away with that. Do put some questions in the chat, and I've only got 2 minutes. Can I ask you one thing, Ajay? I think, well, first, Phil, a comment. I think there's a real case for advocacy of funding for radiotherapy internationally as well. So Sarah, on your list there, because this needs funding. But also, this is amazing. This is one of the first. This is a really advanced, technical, global trial, which is amazing. But in terms of now the essentials document, how do we put that in terms of we need to be introducing these things? Ideally, we had all these randomized trials and all these kind of things as a way ahead. How do we balance the now with the future? I know you and Yolanda are doing some work on what needs assessing, what not. Have you got a vision for how that could look in an essentials document?
Yeah, it's a really good question. So it's horses for courses is the way I describe it, which is a very British phrase. Not everything needs a randomized controlled trial, but we need to have robust evidence in the settings we seek to deploy. Whether we like it or not, a lot of the AI is developed in high-income systems with high-income patients, and it's a completely different ball game in other countries. So I think we have to be cognizant of that and respectful of it to make sure that what we propose works. So I think what this is about is setting both a set of values as to what's important when you integrate into a health system. So affordability, sustainability, and evidence. I think second of all, what you mentioned around pipeline funding. So actually within cancer plans that actually technology like this will come along. There needs to be contingency to be able to test this at pace so it can be integrated. I think third of all, the community as well needs to get together to see, well, what is it willing to accept in terms of the different AI elements that are coming through. What are the pressure points? Where do we need either more innovation or more testing? So I think an essentials list would look at, well, here's the cancer pathway. Do we need it in prognostication? Do we need it in patient selection? Or do we need it in actually, we don't have a pathologist, or there's 3 pathologists in the whole country. That's our pressure point, or our imaging analysis. So I think that also needs to be considered, where at what point in the juncture we're going to invest in our time.
Yeah. And Mary's just put in the chat, of course, as well, to make the case not as a cost, but also making best use of the resources you have. Getting back to the advocacy, I just think that was such a great piece of work, Sarah. And certainly, as you say, there is in the advocacy toolkits already out there, and see how useful it was also to advocate for other people. When we had the task force in Ukraine, the community ended up advocating for others as well as ourselves. And was there anything else you needed, anybody else wanted to say about in the essentials document? what other comments about the advocacy? I guess the main thing is, as you've said, it's horses for courses, as Ajay's been saying, and different people have different pressures.
Yes, and I think whenever we've been working through this process, where we're at is that advocacy itself isn't an essential standard, but this piece will sit alongside kind of the implementation of this within how we do this, because, and it does depend on resources, but what we can do collaboratively globally is help. You know, we can look at what we're all doing individually and maybe pull together different things that have worked really, really well for us. You know, the international benchmarks is really important. And I think GCR and other organizations are doing really good work in that area. But it's also about thinking, how can we just create something that somebody can lift and advocate with, you know, because if we have limited resources, then we don't have the time to be going out and doing that. You might have the data, but you just need to be able to slot that into something.
Yeah, no, very good. Great work. Well, look, we've run out of time. Can I thank everybody for their, Darian's just going to close with 30 seconds about the next step, but thank you so much. Brilliant. We're getting there. So Darian, some thoughts.
I just want to invite everyone to register for our additional phase 2 or phase 3 session 2 webinar on the 26th. And we're going to have the link in the chat. So if you're not already registered, please do go ahead and register for that. And just a big thank you to everyone for participating in the working groups. We know this was an international effort. I mean, you saw the list of people who were joining and also joined us today in the webinar. And so thank you all for joining. And as Pat mentioned, we are just pushing forward with this resource and these efforts. And we are planning on doing a soft launch for London Global Cancer Week. So if you would like to register for that, we'd love to see you in person in London, but also it will be virtual because that's what the GCR is. We are international and virtual. And then my last note is that if you have additional questions or comments, we will be getting the recording out to everyone and we'll have the notes for everyone from the chat. But if you have things that you'd like to include, please send us to admin@globalradiotherapy.org or send the comments in our contact form on the website. So thank you all for joining, and thank you to our presenters as well, Sarah and Tim and Ajay.
Great. Okay, everybody, thank you. We'll see you again. Bye-bye.